Welcome to the Last Visit First Next episode. Today I get to introduce Dr. Danielle Kelvas as a physician entrepreneur and medical marketing leader who bridges frontline clinical experience with high-impact health communications. She earned her MD from East Tennessee State University, which I have no clue where that's at.
It's hidden in the mountains. It's beautiful.
She's trained in emergency medicine and family medicine. And then she also did a stint in concierge medicine. So we're going to talk about that. She's the founder and chief medical editor of DKMD Consulting. So we'll learn about that. She's also an advisor in medtech and digital health organizations. She's a physician-led marketing and content strategist, as well as the next guest on the Last Visit First podcast. So welcome, Dr. Danielle.
Thank you for having me. Good morning.
All right. Start from the beginning. Tell us how you got here.
Yeah. Hands down, the most important thing that I've ever done in my life that impacted my career in so many different ways. And I could talk about my medical training and all of these things. To date, it has been the fact that I did the world race.
Really?
Yeah, I did.
Tell us more.
I did the world race. I had just finished college and I wanted to travel because once you start medical school and things, your life is just over for like 12 years.
Sure.
You can't do anything else.
Sure.
You have to be laser focused.
For sure.
And so the world race, you do 11 countries in 11 months, and it's for young people, and it's just medical missions. So you go all over the world. You work with brilliant people with a servant heart, and but before you do this trip, they fly you to DC for 1 week, and it's an entire week of just training in feedback and cultural competence. So these hardcore communication skills. And at the age of like 20 or 21, getting a week of feedback was very difficult.
Sure.
But it made me so much more better prepared to handle some of these larger conversations that I had later in life as a physician, and now that I'm in business. The art of giving and receiving feedback it's just so critical.
Sure. So tell me about the world race. So you go to different countries and support people. What are you doing?
Yeah. So, like the first country we went to, so they put you on a team of 6 and you have a team leader. And like the first month, we went to Ireland, and then they put us in a kids camp way out in the mountains in Wicklow. And I wanted to go into medicine. So they would find ways to plug me in to medical volunteer opportunities. And so I shadowed a nurse that was managing like the medications in the medical tent for this entire kids camp.
Wow.
So that was like a deep dive into pediatrics. And then from there, we went on to Ukraine and Moldova, which was such a great experience. I'm so lucky that I got to go to Ukraine, before all of.
And what year was this?
Oh, gosh. Oh, it was over 10 years ago, 15 years ago. It was right after I graduated college. So 2008, 2010.
Yeah. Ukraine was totally different then.
Yeah. Oh, yeah. And it was before the Civil War. Like everything there was still pristine and
That's
gorgeous.
Cool. Wow.
And so then I got to do a lot of medicine with the gypsy populations in Ukraine, in Moldova. But all right, so you're working with people from all over the world, all these different languages, different ways of doing medicine. And you're with this team of 6 people every day, all day.
Wow.
Okay. There's going to be conflict. There's
Sure.
nothing you
Sure.
can do about it. Okay. I
For
don't
sure.
care if you're male or female. And so every single day we would finish clinic or whatever volunteer that we did that day, and we would have feedback for like at least an hour.
Wow.
And so you'd have everybody in a circle, and you would go each person, what went well, what did not go well that day. And it was to call life out of you. So it would be like, hey, Danielle, when you do this, it makes people feel like this. In the future, maybe you could phrase it like that, or you
Wow.
could approach this person like that. And I think it will help you as you progress in your career. We did that every single day. It didn't matter if you'd been in the airport for 16 hours and you're exhausted, we're doing feedback.
So did somebody figure that out and that's what they wanted to do, or how did that become about, the feedback part?
Oh, I think it's because when you're on teams like that and you're so pressure cooked and you're traveling and especially going to and we went to all kinds of third world countries, you're going to have disagreements. You're going to have conflict. And especially at that young age, it's so important to learn how to emotionally regulate and then communicate your issues with other people in a way that you resolve the conflict but maintain the relationship. And I think in this era now where everybody is just texting and things, I think we're losing that
For
art
sure.
of
It's
communication.
gone for the most part.
Oh, yeah. So anyway,
So you did the world race, had the greatest experience of your life.
I really did.
And then how did you follow your career? Keep going.
Yeah. The world race taught me communication skills, how to play well in the sandbox. And then it gave me that servant heart. And that's how I got started with a lot of international medical missions trips. And when I got back from the world race, I knew, like, without a shadow of doubt, I want to go to medical school. I want to dedicate my life to serving others in medicine. And the rest is history. I mean, med school, residency, worked in the ER. That was fun until it wasn't. And then I tried primary care. And then I tried concierge medicine, which was, I absolutely loved primary care concierge medicine. I could spend as much time as I wanted with a patient. I wasn't rushed. And we're
Right.
going to get into a lot of those metrics and things later in this interview. But then the pandemic hit. And I was on call every day for 2 years.
Wow.
And I loved my patients. I still do. But I was exhausted. I was a shell of a human being by the end of that.
For sure.
And so I left that with a very heavy heart. I left that clinic and I just took 3 months off to just breathe.
Wow.
But during the pandemic, I had started to receive a lot of writing requests because everybody during that time went online. That was the emergence of telemedicine, telehealth. And so you need to have healthcare providers a part of that conversation. So I started writing, getting involved. And then these companies that I was assisting as a very minimal writer, they said, "Man, you're really good at this. Could you sit in on this meeting? Like, could we get your feedback here?" And then it started, and then it just was this snowball effect. And then suddenly I became this like medical marketer. So it's one of those things where if you've got skills, just show up. I have physicians all the time and nurses that ask me, "How did you get into this? How can I get into this?" Just get in the room. Just do a really good job at whatever you're doing, and people will see your talent, and then they'll help raise you up.
Sure.
And so, like, now I'm at this C-level where I'm a chief medical marketing officer now for, like, Credential Network, which thank you, Credential Network, by the way.
Yeah, thanks for introducing me to her and bringing her here.
Yeah, the CEO, Dylan Avatar, is a great guy.
Yes.
And now I'm at the C-level for this particular company. Now, granted, that took me 7 years to get here. But I saw a need online and I just did my best to meet it. So that's
awesome. So tell me more about Credential Network while we're talking about that.
Yeah, Credential Network's great. So, and we'll get into it more in later on in the interview. But when I was living in California in San Francisco, which I was on sabbatical. You can't have a sabbatical without living in San Francisco.
Wow.
And but the pandemic hit and I said, okay, well, I need to go back into practice. And I took a job at the concierge clinic and I had to move. I had to move to St. Louis. And it was going to take me 3 to 4 months to get credentialed, to get my license, which is absurd. Like, we're in the middle of a pandemic, And so my boss, who later became one of my best friends, she just called the Board of Healing Arts and, a litany of curse words, but just, you need to expedite this. Dr. Kelvas is giving you everything that that you've asked of her. She's paid all the fees, because to get licensed across state lines, there's so many pieces of paper you have to turn in. And it's not just background checks and drug tests and it's your I had to get transcripts from like college, it's very involved. And so my partner running the clinic was going to have to practice for 3 or 4 months by herself. Well, I'm literally living in St. Louis and I can't write a script. I can't prescribe or do anything. And so that's, and that was very early on in my career, but I realized just how inefficient the whole credentialing, it's just a complete and utter waste of money.
It is.
And so then Jeff Falconer, he's the chief business officer for Credential Network. He found me on LinkedIn. I said, "Hey, we've developed this brilliant AI app software that speeds up credentialing, that reduces the amount of time that it takes before you can start a job." And I thought, oh my gosh, where were you 4 years ago? This is fantastic. It's absolutely brilliant. And he said, "Well, we're a startup, But what do you think? I said, I'm in. I'm totally in. I'm all about helping fix some of these big issues in medicine. And so I've been with the company now for 6 months. Great group of people.
So why do you think it is that the government can use PACOs? So CMS uses PACOs to
Hmm.
certify credentialed doctors. But we have to go through this process of credentialing. Nurses, doctors, chaplains, social workers, aides, therapists. Why is it that if I go from California to Nevada, if it's not a compact state, I can't write a script there? The patients are the same. The scripts are the same.
The
The
laws are
tools are the
not.
same. The laws are a little bit different, but why are they different?
Why are they different? Oh, because some things are controlled in some states and in other states they're not. In some states, marijuana is legal. In some states, it's not. In some states, gabapentin's controlled, and in others, it's not. There's also discrepancies in how often things expire. So in this particular state, your license may be good for 2 years. Well, over here, you've got to renew this every year. So we're very disconnected. We're the United States, but what it takes to practice in New York is so different than what it takes over here. And I really wish we could streamline it because I think attorneys and engineers, there's so many other verticals that have it that have just figured it out. And yet in medicine, we're like 20 years behind
It's true.
with credentialing.
But we have a shortage of doctors. We have a shortage of nurses, nurse practitioners, PAs, all these people that are taking care of people.
A shortage of everything.
And we're breaking the system because we're saying, because you moved 5 miles across the state line, or
Yeah.
because you went to St. Louis versus San
also-
Francisco. Now, and there's money involved, right? You got to pay the fees. I got to do all the
Yeah.
things. I got to get credit. But why? I mean,
It's risk mitigation.
I know, but it should be so easy to solve.
I know. It's right. So I have a lot of theories behind this, but healthcare systems, and it's a business, right? Like we need to balance
Business.
our budget, but businesses feel safe when they're mitigating risk. Patients get better and do better when they feel safe. And we actually just published a blog on psychological safety. It's fantastic. Please go read it on the website. But healthcare systems prioritize what? Documentation, ICD-10 codes, billing, revenue, speed, scale. Whereas healthcare providers and patients really, what do we care about? Trust, translation, and time.
Communication.
And yeah, communication. And so they're two very different languages. And they have to learn how to talk together.
It's true.
And it's not us versus them. Nobody wants that. Administrators and CEO, like they want their providers to be happy. But we've developed, I think, this disconnect. People aren't talking. They're siloed. And the internet's great for that. The internet's great to polarize people. We're not going to get into politics. But we need to learn how to, and again, this goes back to the communication skills that were beaten into me at the World Race. Shout out to Chuck and Megan for putting up with me back then. Thank you. But getting people in the room and learning how to speak that language. And so you're going to hear me say again and again and again, we need to marry marketing and medicine. We need to marry the business side of health business and health care.
For sure.
Because they both have to work together.
It's amazing to me, though, if you're taking care of a 93-year-old CHF patient in San Francisco, and how you treat that patient and the care you provide them is probably exactly identical to the patient in St. Louis.
Almost. Yeah. I mean, there are some social determinants of health.
Yeah.
Somebody in California, just statistically speaking, is going to make more money than or than someone, say, in very rural Mississippi.
Sure.
I mean, Mississippi is unfortunately one of the most underserved, poor. It's almost like a third world country.
Right.
And I've done some medicine in Mississippi. But yeah.
But the care you're going to give is probably the same. The social determinants, you may have food service or transportation or water or electricity, those kind of things. But I mean, what you're going to do from a medicine perspective.
Oh yeah, that's identical.
So why does it take a different license? Blows my mind.
Why does it take a different license?
Well, I'd have to be credentialed. It just blows my mind. Like
there's no good answer.
Right.
There's no good answer.
Yeah, it's right. It's money. It's the business of it.
Yeah, it's money.
We have more nurses that are graduating college right now that can't get a license in California because California controls the number of nursing licenses that they release every year.
Mm-hmm.
But we have a shortage of nurses. It blows my mind.
And it's extremely expensive.
Sure.
Because there was, I think, one hospital in San Diego recently, Kaiser went on strike. I think someone actually lit the hospital on fire. Anyway, they're flying nurses in, right, locums tenens, from all over, and you have to pay them like $150 an hour, which is insane.
Right.
Like the system can't afford that.
Right.
So we need to expedite licensure, and that's what Credential Network is about.
Right. You and I talked, I'm going to skip down to a question because I think it's an important piece to put in here. You and I talked about the categorization of and this is a little bit political, but I'm not trying to get political, the big, better bill or whatever it's called. And the professionalization of nurse practitioners and PAs and nurses versus not professional. Explain that. And I didn't realize how important this wasn't going to be until you brought it up to me. And I'm like, holy crap.
I wrote notes.
Okay. Tell me about this.
I have notes.
So you've studied this, I know. So tell me about it.
I have bullet points. So the Department of Education, because of the issues with student loans, which the student loans are out of control, we need policy changes there.
For sure.
I mean, you look at these kids are graduating with over $500,000 in debt. It's a hemorrhage. So something needed to be done.
Correct.
The Department of Education, how do I say this? Certain healthcare providers are now no longer classified as professionals. And so there was a huge backlash online, people thinking, I've been demoted. That's not what this means. If you have a doctorate, right, a doctorate of pharmacy, a doctorate of nursing, you are still labeled a professional. And it changes the type of graduate loans that you can pull out. It changes the cap, how much, how long you can have them for. There's certain caps for like your loan forgiveness, which a lot of that it's changing. But to be, and it's not demoted, it's just a change in the classification of the type of loans you can pull out. And this is good for a lot of reasons. As a nurse, okay, and I'm just making numbers up for just the sake of argument. Say you come out of school and you make $60,000 a year. You should not be, the system should not even allow you to pull out $500,000 in student loan debt. So these are guardrails. You're not being demoted. They're guardrails. Now, when policy like this changes, it takes 2 to 6 years for us to see the downstream effects for it to propagate. So this is where my notes come in. It's primarily impacting our mid-levels. Okay, so nurses, nurse practitioners, PAs, audiologists, physical therapists. We're going to publish an article on our blog that's got like the full list. This will be like a long form article where we've broken it down for people so it's easier to understand. If you go to the Department of Education website, it's just legalese. Like none of it makes sense. Yeah. So we broke it down. So is this going to limit how much people can pull out for school? Yes. Is it going to reduce the number of students and stuff that come out of school? Yes. So,
and that's the fear, right? We need more, but we're making it harder to go get more.
Yeah. So so it's a give and a take. It's a yin and a yang. So when you expand financing for students, you're going to see programs rapidly fill more seats. You're going to see online and hybrid models proliferate. So people who make a career shift, they go back to school later in life. You're going to see more of those, which those are much more mature, seasoned. They tend to be better employees, versus someone who's 18 and is still trying to figure things out.
Sure.
You're going to see geographic diversity increasing. And then just your pipeline in general. So the amount of nurses, PT, you're just going to see more. But when financing tightens, which is what we're going to see, enrollment will contract very quickly. You're going to see a lot of the smaller private programs closing first, which is not what we need.
Right.
Rural and second career applicants are also going to decline disproportionately. And so what does this mean, for our executives looking down on all of this? Workforce shortages often begin with financing policy, not hiring conditions, okay? Programs like the public service loan forgiveness, that practice is more about selection than specialty preference. And so if your policy is stable, your graduates are going to choose primary care, community health, underserved markets. They're going to want to stay close to where mom and dad are. Well, we're going to see less of that.
Sure.
No, people are not going to want to go work at the VA hospital. Um, when the policy is uncertain, you're going to see a big migration towards people working in high dollar specialties, procedural care, where they can bill more, where they can make more money. They're going to want to live in bigger cities, larger health systems, so they can make more money. They're not going to want to work in rural areas, and so it's really like it's one of those really really tough decisions because I think it's criminal how much money students are allowed to pull out, and they have no hope of ever paying it back. But then in the next 2 to 6 years, we're going to see a contraction in all the things that I just outlined.
Sure.
And these are already huge problems that we're having with staffing shortages.
Sure.
So it's the devil you know over the devil you don't. It's really hard.
Do you think it was intentionally done, or do you think it was just part of the overall policy building that caused this problem?
Yeah, this is an excellent example of financial hemorrhage. You
Sure.
have to stop the bleeding. And the
Sure.
bleeding is, as a country, like we're going to have entire generations who can never get ahead because they're drowning in student debt. So we say in the ER, you can stop all bleeding with 2 fingers. Doesn't matter how big or where it is.
Yeah.
This is that hemorrhage. And
Right.
so we have to see policy change with student loans. And then all of these other downstream effects we're just gonna have to figure it out. I mean, I definitely think certain healthcare providers could get paid more. So there's, the cost to income ratio. If tuition rises faster than salaries, you're gonna see an applicant quality shift. Our graduates are not going to be as skilled or as brilliant. They're just not. Um,
What was the other thing we were talking about? Physicians are no longer getting a grade in school; they're just getting a pass fail.
yeah,
Explain that one. I'd like to also thank our premier sponsor, Telehealth. Telehealth is used on a daily basis to figure out where doctors send referrals, as well as facilities. There's all kinds of data in the home health and hospice space inside of Trella. We use it a lot for acquisitions. So when we're looking at agencies that we want to be acquired or helping agencies create de novo strategies or market studies, they look at it to figure out, do you dominate a community or not? How many Medicare lives are in those communities? And then how many hospice or how many home health patients are there in those communities? Telehealth also has a CRM product that allows sales and marketing to have clinical intelligence as well as market intelligence to steer them in where they're calling and making sure they're doing the right amount of calls, as well as documenting their sales calls inside their product. You can find them at trellohealth.com. We'd like to thank Home Care Home Base. They're our premium sponsor as well. Home Care Home Base is the leading EMR in the home health and hospice space, serving over 50% of the patient population. What that means is every other patient is essentially on and being passed through the Home Care Home Base system. You can reach them at hchb.com. Please reach out. This is a little hot button for her. As a physician who practiced in
this isn't strong enough, but we're gonna do this. So in medical school, there's a series of board exams that you have to take.
For sure.
So I took step 1, which was like an 8-hour, multiple choice exam, and then step 2, which is another long form multiple choice. It was like 8 or 9 hours, and then step 2 CS, which is there's like actors. So like I don't know, there's like 8 or 9 patient actors, and you do simulation visits.
Yep.
Which I think is so critical for all of our foreign applicants coming in. That exam is more, are you fluent in English? Do you really know how to do an exam with a patient? Not is the diagnosis correct or not, right?
Right.
Like you're halfway through med school. Your diagnosis is probably incorrect,
Right.
but can you speak? Can you speak well? Step 1, you get a number, and when you go to apply for residency, they're looking at like a host of things, not just your GPA and not just your letters of recommendation. They need that number to know, did you master the basic sciences? That's what
Correct.
makes you a physician. That's that critical thinking. That is what ultimately allows you to diagnose. Now, do you need to be brilliant and make like the highest score possible? Like, no, but there needs to be a way that you can quantitate the difference between your applicants.
Sure.
Because a residency can get thousands of applicants, and maybe they've only got 10 spots. Like how do you filter through that? So a couple years ago, they changed step 1 to pass fail.
So everybody's equal, or they either yes or no.
Program directors were not happy.
Sure. I'm sure they weren't.
How are you supposed to determine
Who's the best
the
resident?
competitiveness of your students? But and initially the argument was because step one is extremely stressful. I remember how stressed out I was. I mean, I didn't sleep for weeks. I think I lost 20 pounds. But because step one is one of those things where if you fail it, you're just screwed. Like you can take it again, but the whole world will see that you failed it once, and you're gonna have a very difficult time matching for residency.
Right.
And this isn't about fairness or right or wrong. This is just the reality of how competitive, because you're not just competing against medical students in the United States, you're competing against students all over the world.
Right. Who are trying to get into that residency.
Yeah.
Sure. Who we need, by the way.
Who we do need. So we go to pass fail. People become a lot less stressed. Program directors don't know how to rate their students. Looking back, and I mean, do I miss that level of stress? Like, no. But if you can't even handle the stress of a computer test, you're not going to do well in medicine.
In a human test?
No.
Exactly.
Well, and the thing too, Tom, people are not multiple choice questions.
Right. They're not.
They're not. I don't
Sure.
have ABCD.
It's true.
Do you know what I have? I drive to work every day looking at all the attorney billboards
I know. That's right.
for when I mess up.
Or watch TV. Yeah.
Yeah. Or have you been watching the Olympics?
I have.
All right. Have you been seeing all the ads for Tiger, that attorney?
Oh my gosh. It's so bad here. She's here. Jungle. It's
Jungle.
Yes.
Oh my gosh.
It is so bad. She flew a kite around behind an airplane, behind the waste management the entire time. Like it's jungle attorney. It's essentially, it's crazy. Yeah. It's not
hysterical.
It's the worst kind of attorney in the world.
But anyway, so to bring it back and answer your question, medicine is not pass fail. Do you think when I'm treating a patient, I'm like, oh, I passed?
Right.
No, it's not black or white. Treating patients is such a long gray scale. I am not for the pass fail. And somebody issued a statement. Was it the AMA? I'm not sure if it's the AMA. Don't quote me on that. Somebody big issued a statement like, oh, we made a mistake. So they may get rid of that.
For sure.
We
have to have some kind of classification to say who's the best. Because I also want to, if you're a cardiothoracic or electrocardiothoracic surgeon, that's a little bit higher advanced skill in physics and computers and electricity.
But your surgeon passed.
I know. But you want to have the best of the best.
I know.
The best going in that, right?
If somebody's like, well,
neurologist,
how did you do on your boards? Oh, I passed.
I passed, yeah.
I don't know. It's weird versus like, did you make an A? Did you make a C? I don't know.
I can't remember the last time I asked my doctor, though, what'd you score in medical school?
Yeah. And no one's going to remember.
No one's going to remember. Yeah.
But,
But you want to have the best. I mean, and how do you classify people as the best? Who get our problem? Back to your student loan thing, I'll tell a story. So when I was at Home Care Home Base, I was the chief operating officer and chief strategy officer, and we were hiring these kids in. And I'm not going to tell you the guy's name. He still works at Home Care Home Base, but he came in and he had been in 5 years of school, and he got into Abilene Christian University, and he had over $350,000 of debt. And I'm paying him $75,000 a year to run a call center. And he's like, Tom, I can't even make my student loan payment on $75,000 a year. I'm like, you're not qualified to make any more money than this. This is all we could pay you. You're equal to your peers. He's like, I don't know what I'm going to do. I'm going to go get a second or third job. And he literally had a second or third job just to pay his student loan debt because he couldn't afford an apartment, a used car, groceries, a little bit of fun, and a student loan debt because he had so much money. And so I don't know why this school, one, let him have that much cash. Two, what did he do with all that cash? No clue. But somehow he was able to borrow that much money, and then he was in major financial crisis.
Yeah.
And that's going to go on for a long time.
Oh, it's going to take years and years and years. I mean, this is the first time in history where my generation has less money than you guys did at my age. So let me say that again.
What, am I a different generation than you? Are you aging me?
You're one up. You're one up. I'll say that again.
I am.
It's the first time in history where, so I have less money at my age than you did at my age.
Probably right. That's what I was in the military at your age.
Yeah.
I was broke, but it's true. It is absolutely true.
I have friends and colleagues who have between $500,000 and $700,000 in student debt.
It's crazy.
It's totally unacceptable.
It's absolutely wild.
I mean, you can't. How do you buy a house? How do you
Can't.
how do you start? How do you save for retirement? You can't.
Just because they wanted to be a doctor, they had passion to treat patients, and they went and got a bunch of loans so they could be a doctor.
Oh, yeah. And I have friends that were in medical school or college with me, and they were doing the whole medicine pathway, and they dropped out when they started to really do the math. And then, like, one of my good friends, he went into medical device sales and, made buku money. Like, he's so brilliant. And I look back and I was like, yeah, he was a little bit smarter than me. Now, I loved taking care of patients. I still do. To me, it was a calling, and I have no regrets at all. Did I make the most financially wise decision? Absolutely not.
Right.
There's so many other things I could have done, and I would have so many more millions of dollars in the bank, and I probably wouldn't have had student debt and all of these things. But that was the best decision for me.
For sure.
Um,
Yeah, it's a calling, but then you got to justify, is this calling? Because I remember when I was a kid, the doctor in our family, and I lived in Amarillo, Texas, so we had a small town community, small rural community. I mean, the doctor would come and see Nana. I mean, he literally, this is in the late 70s, early 80s. I mean, he would come with a bag and come into Nana's home, and they were like the most brilliant people ever. They were the smartest, the most well-respected, all that. And then people went into medicine for those, those stories, and then they get in there and then now they're full of debt. So, all right, let's not dwell on that too long. Let's go back to your ER days. I was an ERPA. I spent a lot of time in the military, in the ERs. Any great story that comes out of that just like changed your life? Or, I mean, I'm sure there's hundreds of stories, but ER is a tough area. It's the most high stress. It's also the most fun.
I had a blast. I loved it, and I miss it. I really do miss it. I have funny stories.
Yeah, tell me some.
Funny story. My first intubation, I was in medical school, and this guy was like 400 pounds. He was at a dentist getting teeth pulled, and the dentist was very brave. So normally when you do a procedure like that and you sedate the patient, right, you have somebody doing anesthesia and somebody actually doing the surgical procedure. Well, the dentist was bravado and said, oh, I'm going to do it by myself. Okay. So, of course, the patient crashes. And they call an ambulance. We bring him in. And this was before, like, I was really working out, so I could, like, not get this guy's head up. I mean, you know what it is to intubate someone. You have to, like, lift their head. And I thought it weighs 1,000 pounds. And my attending's yelling at me, like, well, you need to work out. And I'm like, I'm trying. And I finally get him intubated, and there's teeth and everything everywhere. And I'm like sweating. Okay, like pit sweat. I'm like, okay, I didn't kill him. I made it. And this beautiful woman walks in, and she's like, hey, I'm here to see my boyfriend. Is he? I was like, yeah, he's in room 16. Like, and I ran her through everything we did, and he's stable. I probably just need to wait for the anesthesia to come out of his system, and then I bet you we could extubate him in like the next day. He's not going to be here long. And so then I go see a couple other patients, and then the nurse comes to me and is like, hey, his wife's got a few more questions. I said, sure, no problem. It's a different woman.
Uh-oh. Uh-oh.
And I'm looking at her, and she's like, hey, I just got off work. I heard my husband, he's here. Can you run me through it? And the blood just leaves my face. And I'm like,
uh-oh.
Oh my God.
That's crazy.
So I give her the same again. And I was like, room 16, gotta go. I was like, I'm not going to be here for this. And that's not the first time that's happened. Yeah. But you learn to ask, what's your relation to the patient? You don't just assume.
That's true.
Anyway.
Yeah. Did I ever tell you the story about Dr. Conley in the ER?
No.
So I was in the ER in Corpus Christi. No, I was in Orlando, sorry. And we had a patient come in just screaming Bloody Murray. And we couldn't figure out what was wrong with her. And she kept grabbing her ear and couldn't figure out what was wrong with her, And we thought drugs, something bad, psychotic, whatever. And so we papoosed her. We gave her some Versed to calm her down. And I pulled out the scope, and I got to figure out what's going on with this ear. Because she kept pulling on her ear, and I looked in there, and there's a cockroach in her ear.
Yeah.
Crawled into her ear, and I'm like, all right, how do I get a cockroach out of her ear? I had no clue. She's screaming Bloody Murray. And every time you get close to her, it's worse. And so I go into Dr. Conley, who is an old ER doc in Vietnam, super smart guy, one of the greatest guys I ever worked with. And I'm like, Dr. Conley, back then this was in the 90s. We didn't have Google and all this crap to see how you do it. And so I'm like, how do you get a cockroach out of this ear? As soon as I get close to her, she freaks out. And so Conley goes, oh, I know how to do this. I did it in Vietnam. And I'm like, okay, show me. And so he grabs a needle, an 18 gauge needle and a syringe full of alcohol.
Yeah.
And he pulls the cap off the needle, and he puts the cap on this side of her ear and pushes in her eardrum. to see how deep her ear canal was.
Uh-huh.
And then he grabs a wooden tongue depressor and tapes it on that needle at the exact same distance. He tapes it really tight. And then he walks over and just goes, and the tongue depressor stops the needle from going through her eardrum.
Uh-huh.
And he just blasts the cockroach, pulls it out. And she wakes up normal, thanks him, hugs him. We pull out of her bags, sign the paperwork, and get her out of there. But literally, I thought, this is one of the hardest cases I've ever had. Just freaked me out. I didn't know how I was going to get that stupid cockroach. I was just going to grab it with tweezers. But when you grab it with tweezers, it grabs the legs of the cockroach, grabs her ear and freaks her out. And it's trying.
You could rip her eardrum.
Right. And she's trying to crawl. It's trying to crawl through her brain, right? It's scared. And like, he just goes up, he's done. I'm like, holy crap, Conley, you're the most smartest guy I ever met. You
know that expression, keep it simple, stupid?
Yeah.
Kid.
He was. Yeah.
Yeah. Some of the most difficult things in the ER. It's like, no, actually, easier than you think.
I had so many stories at ER. I mean, oh my gosh, it was fun, but these poor patients would drive in Florida. They'd pass 13 to 15 hospitals to get to our ER because it was free. Oh. And it was the spouse with the husband. And, you get there and he died 12 hospitals ago. Oh my she God. Passed all of them, but she didn't want to pay any money. Yeah, I don't know how many times that happened to us. She'd go out there and like, come get my husband. He's struggling. He's struggling. I mean, he's like ice cold. He's been driving in the car for an hour. You're just like, man, he should have stopped at the hospital.
Yeah, how do you have that conversation?
Right, but it's like, they didn't want to pay any money. So
but that and the literacy, because I've worked in some really backwoods hospitals all over the United States. It's alarming.
I thought you were going to say in Tennessee.
And Tennessee, yeah.
Sorry, Tennessee.
Craziest stuff is like the Appalachia.
Yeah.
How many people can't read?
It's true.
Like people our age and they get in the car and they drive, can't read. Like, and you can start to pick up on it. Like they'll have like a bag of medication because you'll ask them, what do you take? And they just put the bag down. You're like, okay, well, do you take your heart medicine? And they're like, can you show me which? And they can't read.
Yeah.
They have no idea. How do you explain heart failure to somebody like that?
They're just taking all the meds.
Yeah. And they're taking it wrong and they're not taking it at the right time or.
I have another funny story. Lance Corporal, and I'm not going to tell you his last name, Marine from backwoods, Louisiana. I mean, he's from the country. He's funny. He talks funny. He's one of the fittest, most, strongest Marines we ever had. Could shoot a gun better than anybody. And so he comes in, he's super sick and he's throwing up. He's got diarrhea, throwing up, he's high fever, all that. So I give him suppositories. And he comes back the next morning, comes back to the battalion aid station, and he's like, Doc, I don't know what's in that medicine, but I can't not swallow it. And I'm like, okay, how stupid are you and how stupid am I for not explaining to you that a suppository goes up the other end? You don't eat the suppository, but he was trying to swallow those
shut up your nose.
It's so funny.
Nasal rocket style.
I'm like, are you kidding me? You don't know what a suppository is? He's like, I've never heard that word in my life. And I'm like, okay, there you go. To your point, like they can't read, they can't write. He's never heard
I've had patients, they spray the inhaler on their face. Like nobody even bothered to show this patient the inhaler goes in your mouth. And you inhale. Yeah, I've literally had a woman spray.
But it goes to show you we have to teach people how to. I mean, if you've never been around healthcare and you've never been in the hospital, and we have to teach them, right?
I have preached this my whole career. Slower is faster.
Yep.
And slower saves money. It reduces bounce backs, readmissions. People have better outcomes. Again, it goes back to time, trust, translation. But health systems don't prioritize that. And it costs more money.
Because we're seeing 18 to 20 patients a day, or maybe 30 to 40 patients a day in some scenarios.
When I was an intern, okay, I've been a doctor for like 5 minutes. It was like my first week in residency, and I cried every day. I was like, I don't know if I can do this. There were some shifts I was seeing 35 patients a shift, which is insane. That's what like a seasoned board-certified attending does.
But how do you do your documentation correctly? How do you chart correctly? How do you review the chart correctly? How do you review the labs correctly? It takes you 5 minutes to review the labs. Yeah. And we don't have technology back then. We didn't have it when I was PA. You didn't have it then to help you decipher what you need to look at and what you don't need to look at.
Yeah, the technology now is a little bit better. But I would argue the technology has also slowed us down.
It has.
It really has.
I agree with that.
Because, I mean, like when you and I started training, right, I was still learning how to do the shorthand on paper.
For sure.
And that's a dead language now.
It is.
A couple weeks ago, long story, I had to write a paper prescription. Something happened. And I was like, and you write the little C with the line on top.
Yeah.
And you're like, oh,
With-
nostalgia.
with-
That little nostalgic, like how to handwrite,
Yeah.
like to have a prescription pad.
Yeah.
It's gone.
Yeah. Gone.
It's gone.
It's all
It's never coming back.
e-prescribing. Yeah. And I don't know that we do less medication errors with the new electronic stuff.
No, it's
probably the same-
more.
probably
You know
the
why?
same.
Because there are people on polypharmacy. They're on more drugs than they ever used to be.
True. So true. It's bizarre.
Everybody's on like at least 10 pills.
We were having a conversation about this a couple weeks ago, and with one of my other companies in Metalogics or Mosaic, and we were looking at the number of medications that patients were on, and on average, that especially in the home health and hospice space, there are 10 to 12 medications, and they're taking them twice a day.
Mm-hmm.
If you're taking 12 pills, I take 5 vitamins, and I don't know, there are all kinds of vitamin D, BC, optimized from 10X Human, and there's 5 pills, and it's like really hard to take 5. I can't imagine taking 20. It's like a cereal bowl full of medicine. And all that going in your system either at the same time or within hours apart. Some of them you're supposed to eat with, some of them you're not. Like, how the heck are we not having more contraindications of medications?
Oh, we do.
I know.
And they end up in the ER.
I know. And they're having all kinds of problems. All of them do. They all go back to the ER. It's the number one reason why patients go back to the hospital. Medications, because you're on 25 meds.
Well, so you have one illness, and then you have side effects, and then you take pills for those side effects. And there's side effects, and you take pills for those side effects, and then you're 10 or 12 pills in.
It's crazy. And then you have multiple doctors that are giving you multiple medications. Sometimes
And they're all
the
so
same.
busy they can't talk to each other.
Agree. So is that what's wrong with our healthcare system?
No.
One of the reasons?
If I had to summarize what is wrong with health care, it's that it turned into health business too quickly. And we didn't have everybody at the table discussing.
For sure.
It was a very rapid change. It seemed like in a matter of minutes, everything was electronic health record. Everything was Pyxis. You remember when all the drugs went into the Pyxis?
Yep.
And then the barcodes?
Yep.
I can't even go get a pillow for a patient. I'm serious.
Yeah.
A nurse has to go get it. I can't even get the pillow.
You have to scan it, pull it out, charge them for it.
Yeah. And then health insurance got involved. And health insurance is important. I know everybody likes to make them out to be the bad guy, but get rid of your right versus wrong and let's just look at the numbers, right? People are able to get care that they would not have been otherwise been able to afford. Now, did health insurance inflate prices? Yes. But there needs to be better checks and balances, right? So we see this in government. You have the Supreme Court, you've got
Sure.
Congress, you've got the Senate, you've got House of Representatives. We don't have that in medicine. And so you've got people running a business, making business decisions, which are wise decisions. They need the hospitals to balance their budget. But you need to have healthcare providers and other people sitting down at the table to discuss these decisions as they change. Physicians and healthcare providers used to have authority, liability, and responsibility. And we've lost our authority. So now all we have is responsibility and liability. And it's why all healthcare providers are stressed and burnt out and they're quitting.
For sure.
So
let's bring this back to the last visit first. So we're talking about home health and hospice.
yeah.
So you're an ER doctor, you have patients coming in all the time that you should be having the end of life conversations with them, or you should be having the, hey, what are you going to be doing in the next 6 months, 8 months, 12 months? What are some things that you as a doctor have learned through that process that would, one, help the home health and hospice agencies better serve those patients, or better, one of the biggest challenges I think we have is it takes us a long time to admit a patient, and we should be able to admit that patient within 24 hours of being discharged from the hospital, and sometimes it's 5 or 6 days, just because of insurance and auth and process and supply and demand. Thoughts around any of that?
Yeah, absolutely. So it all goes back to what I started with, communication. Okay. The ER is not where healthcare begins to fail. And that's what everybody likes to paint it as. And there's really great TV shows like Grey's Anatomy and The Pit. And they're like, oh, this is like, no. The ED is not where healthcare begins to fail. It's where accumulated small failures finally become visible. Okay. And so it's the place where I thought about this late last night. I was like 1 a.m. preparing my
Yeah, good.
No, these are like 2 a.m. thoughts. It became the place where preventable trajectories finally ran out of time. And so the ED it's the slow collapse of chronic disease. It's that heart failure patient who gained 5 pounds in fluid, but like no one's paying attention. And then suddenly they're fluid overloaded, full exacerbation, and they're in the ER.
No, they can't breathe. They're
Yeah, they
struggling.
can't breathe. Um, and so much of our symptoms, it's loneliness. And so let me explain. Um, Loneliness presents as a medical emergency. Okay, it starts as, "Doc, I just don't feel right," or "Yeah, I'm just really weak today," or "Doc, I don't know, I'm just dizzy today." Right? When you're super sick, you don't have insight. It's impossible to have insight, but we don't make time or space for those little conversations. Um, ED visits are half the time they're unmet social needs. It's isolation, it's grief, it's cognitive decline, and it's caregiver burnout. Um, and then we're also having all of these 2 a.m. end of life conversations in the ER. So conversations that should have figured out, are you DNR? Are we doing CPR? Do you want to be admitted to the ICU? It's happening in this emergent situation versus in a careful, calm, collected space prior. When I was in medical school, I had to have a very difficult conversation with a patient that I just bombed, like completely bombed it.
We all did.
And that's a really funny story that I should tell later in this podcast. But I just realized, like, oh my God, I got to figure this out. Like, I cannot continue in my career bombing conversations like this. So the pharmacy school next door offered a hospice communication class. And I was exhausted. Like, I had no time for this, but I thought I'm never going to have a failed conversation like this ever again. And it was like Tuesday nights, and they would have simulated patients. And for just 2 hours, you would just go in and practice communicating. And they gave you these books to read. And it was one of the best classes I ever took. But that's not a part of the curriculum. You only get that if you like fellowship specialize in hospice.
You didn't learn that in medical school?
No, it was an elective that I had to take.
Kind of like nutrition, right?
Nutrition, we had a 1-day lecture on nutrition.
It's so
And you know
funny.
what it was? It was refer to a nutritionist.
Yeah, I
ICD-10
know.
or ICD-9
I
code
know.
for that.
That would tick me off because now I'm on the health and wellness kick and the end of life kick. Those are two that they don't teach in medical school, but we all go to our doctor about nutrition. We all go to our doctor about weight loss. We all go to our doctor about.
I mean, and we should, but
You should have more training in it.
we should, but have a low threshold to refer to a nutritionalist.
That's right.
And I'm speaking of myself. I thought it would be smart to be a vegetarian for like a year or 2 years. And this is while I was lifting very heavily in the gym. Okay.
Right.
So of course my hair falls out and because my nails look like crap. And so I finally go see a nutritionalist and she's like, "You're getting like half a gram of protein a day.
Yeah.
What are you doing?"
Yeah.
But anyway, so to kind of go back to the question that you had asked, if you're triaging in real time, like what actionable things or advice can you give? So when you're seeing patients, and it doesn't even matter if you're outpatient or in the ER, you're deciding not who needs care, but who needs monitoring. Okay. And so it's not, the question isn't just about acuity. How sick are you? Is your home environment safe enough to hold that level of uncertainty? Can you be monitored here? And so what is that like, so to break down, because I really thought about this question, like what actionable things, and I can send this to you. This is like a
Please.
checklist if
Yeah.
your listeners
For sure.
want to use this
Cole
to go
post
through.
it. Yeah, he'll post it.
So you ask yourself, first of all, where will this patient do best over the next 24 to 72 hours? Okay. If you're genuinely really not sure, admit or talk to the patient, right? Because if they are hospice or palliative care, and it's alarming how many people completely misunderstand what hospice is. They think they know, but the truth, but then when you actually start explaining to them, okay, hospice means we're not going to do anything. And then what do they say? Well, what do you mean you're not going to do anything? Well, they don't understand. It's withdrawing care. It's really just keeping the person comfortable. No, we're not going to throw a ton of antibiotics at you. We're not going to vancomycin you and intubate you in the ICU. Like having those very specific conversations. But so number one, where will this patient do best over the next 24 to 72 hours? Is the patient stable right now? Are they trending stable? Right? And so maybe you just keep them in OBS. Just watch them for 6 hours. If their vital signs are doing this or whatever, admit. Don't just send them back home. So signals favoring like a home-based pathway, normal or near normal vital signs. Okay. If their oxygen is dropping a little bit or this and that, then they're in. Okay. We don't want any bounce backs. Do they improve after very minimal intervention? Okay. No escalating oxygen requirements. Is their pain controlled? Can we talk about uncontrolled pain for just like a brief
Sure.
second? I feel like that's 9 out of 10 bounce backs. People get surgery or they get a procedure and their pain is just so out of control they come back to the ER because they're excruciating. Like they can't, and I've had surgery. I know what that feels like. I had my wisdom teeth out and I thought I was gonna die.
Yeah. Tolerance is another piece of that, right? Some people tolerate pain. Like I tolerate pain really well. Some people don't. And what is pain to you? What is pain to me? And you have to figure that out in every patient.
Well, how are their pain levels?
Right.
If they're in 9 out of 10 pain, no, you cannot send them back home.
That's right.
You're gonna make them go crazy. Anybody will go crazy. You don't even need to be old to go crazy if you're in pain.
That's right.
You know. But then are their labs reassuring? Are they unchanged from baseline? And so if they're stable and predictable and they've got a good supportive environment at home, then you can send them home. If there's an uncertain trajectory in any way, shape, or form, then you obs them or you admit them. And so then kind of moving on, is there a safe landing place outside of the hospital? So is there a reliable caregiver or support system? If I had $1 for every single time somebody was like, yeah, they come to the house twice a week, but they never answer the phone at night. And then they need reassurance. They're not really sure what to do. And so then they come to the ER. And they're not having an emergency. They just needed reassurance. And that's not an ER visit.
That's right.
You know?
We saw so many patients when I was in the ER that didn't belong in the ER, but they were there because they didn't have anywhere else to go.
They weren't sure.
They
Or
weren't
the
sure.
caregiver's exhausted.
Yeah.
I've had patients where they'll come in, they'll say, hey, I've been taking care of my mom. She's got Alzheimer's. I'm exhausted. She is so angry and she's throwing things and I just need a break. And it really sucks to have to say, I'm so sorry, ma'am, but we're not a hotel. Like we can't babysit your mom. She's stable.
Yeah.
She's got, Alzheimer's, but I can't admit her.
That's right.
So you can sleep tonight. I'm so sorry. That really sucks. And you know exactly, you've had those conversations.
Those are tough conversations.
Really, really tough conversations.
We're spending a lot of time, and I mean, it's amazing to me how many patients go to the ER because there's no place else to go. And I mean, we're very blessed in our lives that we understand that, but a lot of people don't. And then you're in a rural community and you don't have anywhere to, I mean, you drive for an hour to get to the hospital, but what else do? You have nothing else to do. There's nobody else to take care of you if you're not on home health. Here's another interesting one for me. So if you're sad, lonely, scared, depressed, you lost your spouse, and so in order to be in home health, the government requires you to be homebound, meaning you can't leave your house without taxing effort. The last thing I want to do is put a sad, lonely, scared, depressed person and force them in their home to be isolated by themselves.
It's why our suicide rates are the worst they've ever been. Right. And this is across all generations. The number 2 cause of death in my generation is suicide.
Scary.
And it's, I think, number 3 for your generation.
She keeps aging me here. I don't know what's going on. It's okay.
I'm going to drink my coffee.
I also like to thank our sponsor, Maxwell Tech. Maxwell Tech is a consulting company that works in the mergers and acquisitions, optimization, implementation, and is also in the tech-enabled space. They have a product called NanaConnect. NanaConnect allows you to text patients' appointment reminders, check in on patients in remote patient monitoring, follow up on patients that have been discharged, as well as automate the entirety of the bereavement process. To get more information, you can email sales@maxwelltech.com or go to their website at www.maxwelltech.com. All right, I want to reach out and thank one of our sponsors, Steno Health. Steno Health is an AI ambient listening tool that makes clinical documentation much faster. Check them out at stenohealth.com. I also like to thank our sponsor, IntelliTriage. IntelliTriage is a human-in-the-loop, nurse-first triage company that simplifies the triage function inside the home health and hospice community. You can reach them at IntelliTriage.com. So what's the largest opportunity to reduce avoidable utilization through better escalation protocols? So how do we keep patients, one, from getting admitted into the hospital, two, go into the ER? What do you think how do we solve this?
So there's, in my opinion, there's 4 things. People need continuity. We need continuity of care. But that's not what makes money, right? Hospital systems, they want throughput, okay? They want speed, triage, risk mitigation. Um, and the Buddha talks about this, and so did Thich Nhat Hanh before he passed. Healing happens in between visits, and the Buddha talks a lot about it's not even about what you say, it's the space between words. And there's so many nuances in there with healing and things. Patients rarely present with a single problem. The real diagnosis emerges over time, time, context, and trust. If you have continuity of care, right? So, like as a provider, and this is why I love concierge medicine so much. I knew my people. I knew when you're just crying wolf. I know when you're mad at your wife. I know when you're actually sick.
For sure.
So to keep people out of the ER, we need better primary care, but continuity of care, right? So you're seeing the same provider each time. It's that relationship. There's a lot of clinics where you'll go and you never see the same person ever. And the turnover is so bad. You don't even see the same nurse. Right? So there's no relationship there.
And that doctor is seeing 35 patients a day.
Yeah, and they don't even remember. They're exhausted.
Yeah. They're tired. They're sad. They don't have time to look at your medical record. And you're like, okay, what are you here for?
Yeah.
That's really what it is. That's how they go in. I mean, I've been to the doctor where he's like, what are you here for? You're like, what? I mean, when I was in the military, we took care of, 100 Marines. I knew every one of those Marines. I knew who had knee surgery. I knew back surgery. I knew where they're at. We did full physicals on them. We knew what their tattoos were. We knew everything about them. And we could tell if they were performing as an athlete or not, because you're an athlete in the military. Then we'd go to the ER and you'd see, just tons of people, kids coming in that shouldn't have been in the ER. They should have went to primary care clinic, but their parents couldn't go to the primary care clinic because the clinic was only open while they were at work or while they were doing their missions. And so here we were.
And it takes 6 months to get in.
Yeah. That's the other problem.
Okay, I just say a patient has a UTI. I'll be dead in 6 months. I will literally be dead.
You could have a UTI for 6 months. I mean, yeah. What? I mean, they go to the ER.
No one needs to go to the ER for a UTI.
No, absolutely.
Ever.
No, absolutely.
You don't come to us unless you have like pyelonephritis, which you should never get there because we should have saw you from the beginning. So anyway, outcomes really improve when you know the patient's story.
But the system is broken from that perspective for the average American that's going to the doctor.
I'm just going to challenge the language because everybody's, it's broken. And it goes back to us versus them. As a business, they've got their priorities. As healthcare providers, we have our priorities. I think we just need to communicate.
Sure.
And so, how can I make an Excel spreadsheet that demonstrates to finance, hey, continuity of care actually saves money? That's our challenge. I mean, I'm still figuring that out. I will let you know as soon as I figure that out.
Sure.
And so then number 2, so how do we keep people, like to answer your question, people want interpretation, not just information. And it goes back to, I used to see patients who couldn't even read, right? So we discharge somebody from the ER, and what do we give them? Here you go.
Have your documents.
Read that. It's a diagram of your kidneys and your UTI.
Yep.
Nobody sits down and explains to them, hey, here's how you clean, or here's how you can prevent UTIs. Here's how you take your medication, versus the lady I was telling you that sprays the inhaler on her face. That's not the patient's fault. That every single provider that patient saw failed her, that she didn't know how to use that.
Yeah, he ate the suppositories. Same thing. So on the home health side, though, and that's what I think home health is, one of the things that home health nurses are really, really, really good at is when they discharge from the hospital and we admit you in home health, 50% of what they're doing is treating your wounds, treating your vital signs, making sure you're stable, treating the environment, treating all the social determinants, but then also educating you on your disease. Here's how you take your medicines. Here's what you do. Here's how you, and so and it's really sad to me. We see
it's devastating.
The number, and so I'm part of Trella Health and use that tool all the time. Trella is like a CMS platform, but the number of patients that get discharged with home health instructions that never admit to home health is devastating.
Yeah, because they don't know.
They will think it's going to cost them more money too.
Well, and they're overwhelmed.
For sure.
I mean, I think back to the last time I had surgery. I mean, it took me like 3 days to recapture. Like to even be able to like read something, if you're so like on pills or, whatever. People, and it goes back to time, trust, translation.
It's true. It's true. Communication for them, translation
100%.
communication.
So, people want synthesis, prioritization. Doc, what should I focus on first? Reassurance, narrative clarity. But the business side, health business, they want ICD-10 codes. They want you to document. They want defensive medicine. They're complete opposites. Medicine doesn't need more technology. We don't. People want a sense of meaning. You give somebody a diagnosis, right? They're terrified to go to the hospital, and they don't check into home health because they're like, at least men are like, well, I don't want to know what's wrong with me.
So true.
Well, why are you here? My wife made me.
So true.
That's every conversation with older guys. But they want a sense of meaning. Well, doc, what does this mean for me? Hey, your A1C is like really high and your blood sugar's awful. Well, what does that mean? They want a sense of meaning. They don't want a packet.
Yeah, exactly.
They don't want that, So the number 3, people seek psychological safety. And we just published an excellent article on our blog, Credential Network, on this sense of psychological safety. If you don't feel safe, you can't heal. Nothing gets accomplished. You can't learn, you can't listen, you can't heal, you can't have autonomy or agency over yourself and your medications, or even the wherewithal to call for help, you know? But instead of psychological safety, health business in the system optimizes like liability safety. And so you're covering your tracks.
Right.
Well, that doesn't make somebody feel safe. That puts them on the defensive.
That's right.
The system wants compliance, risk avoidance, and documentation drills. And that, just makes patients feel awesome. Well, and then what do you say? Well, the patient's non-adherent.
Yep.
You're non-compliant.
Yeah, but you just told the patient that their A1C is off. What does that mean?
What does it even mean?
They don't have a clue.
You haven't given that a sense of meaning.
Right. That's right.
Did you communicate? And it goes back to what I learned on World Race. That is giving a patient feedback. That is a very difficult it's extremely difficult to give a patient feedback. You're getting worse despite taking medication or despite making lifestyle changes. Extremely difficult. How do you get that to land well? That's feedback.
Right.
Hey, if we don't make some changes, man, you're going to lose your leg. It's feedback. And then number 4, health is social and behavioral. And it kind of goes back to all illness stems from loneliness, stress, environment, lack of meaning, lack of culture, lack of community. You were talking about we isolate. But what do reimbursement models favor? They favor medication. Medication doesn't fix loneliness.
Don't.
And procedures and measurable interventions. Well, you can't measure just telling a guy like, man, why don't you join a golf club and just play cards with some guys a couple times a week, or go shoot some stuff? I don't know. Or whatever.
Play golf.
Or go play, or just something, community. You can't measure that, and you can't bill for that. But maybe if they had that, they wouldn't need Prozac.
Sure.
Or, there's like all of these things. So we tend to we fund treatment for the downstream biology, but we don't want to look upstream. So those are my theories on how to keep people out of the ER.
It's true. And I think there's a lot of things we can do in the home health community by working on that. I mean, you find it some in assisted livings and SNFs and skilled nursing facilities where, they have programs and wellness activities, and, they have cards and dancing and dominoes and gatherings and windows. Windows.
It's crazy concept. If we get people sunshine, they do better. Yeah. There's studies that show that. Have you read them?
Oh yeah, for sure. Put my feet on the ground every day and be outside.
Ground.
I live in Scottsdale, Arizona, where the sun shines all the time, so we can get sunshine. It's true. Those are all true things. Get outside, walk a little bit, go to the gym, work out. Florence
Nightingale wrote about that ages ago.
For sure.
About patients need fresh air and to open the windows. And she noticed, she's one of the first nurses. She's like, patients get better when we open the windows.
Amazing, isn't it?
Well, she wrote this whole curriculum to educate nurses. I read it. She's brilliant.
Yeah.
She didn't need technology. She just paid attention to the patient. She just saw me do better with fresh air and some windows.
Yeah.
So she would roll patients out and sit them outside.
For sure.
One of the first people to do that. No Excel spreadsheets needed.
If you guys haven't watched Landman, but
I love Landman.
Landman's one of my favorite shows. But there's a story where his dad is sitting out in a wheelchair looking at the sunset every night. And he sits there every night, and it's the episode where the mom passes away, and but he's just looking the comments that God, what's his name? The dad.
Oh, I don't know. They cuss at each other so much. I don't
Oh, I
even
know.
remember their names.
But if you guys haven't seen this one, he's literally sitting there. Sam Elliott, Sam Elliott, and he goes through this whole statement, but it's really about you watching the sunset every night,
and everybody wants to interrupt him doing that.
I know.
He's like, I'm gonna miss it.
Yeah, but he sits and watches the sunset every night, and it's amazing. But I think about that a lot. Yeah, that's for sure. All right, we got to get into some AI because this thing's about AI. So, you scared of AI?
No.
What is AI? How's it going to help you in your job?
AI is great. Everybody likes to make a big fuss because it's rage bait. All right, so do not have a Luddite mentality. Okay. You think back to, remember when we all used to get our videos from Blockbuster
Mhm.
and then Netflix came along, or,
What a bad business model that was, but a great one. At one time it was amazing and it just blew up overnight.
well, they made a lot of money
They did.
and I have a lot of great childhood memories.
Me
So
too.
thanks, Blockbuster. Remember you could find $2 if you don't rewind the tape
That's right.
to bring it back. All of
That's
these
so
little
stupid.
things.
And then you had to buy the rewinder. So
You had to buy the rewinder.
You didn't have your VCR
No.
rewind it. Yeah, so you had a rewinder.
AI is a great tool. And people are making a big fuss to scare you and to make ads and make money. And that's not it at all. I mean, there's this company that I used to work with. They've developed an AI-assisted ultrasound device. The CEO sent me one. Everyone in my life got ultrasounded for like 6 months. I was like, come over.
Let's practice this.
Sit down. Take your shirt off. We're going to ultrasound your heart now.
And it would actually do the interpretation of the reading.
Yes,
Oh, that's
Tom.
awesome. That's cool.
It's the coolest thing.
Yeah.
I mean, what would normally take a half an hour, 40 minutes, and maybe my measurements are right? Because I'm not a cardiologist. Shout out to all of our cardiologists who did all of that training. But the AI does it for you.
For sure.
And it's probably more accurate. That's something to talk about.
For sure. I'm a big fan of it. And whether we just use it to summarize medical records or we use it to look for drug-to-drug interactions, or I think about back when we wrote technology, we would do these things called buddy codes. And the buddy code would be if the patient's on Coumadin, we need to get a PTI&R every 2 weeks. So the nurse would schedule a PTI&R every 2 weeks. Well, why can't AI just tell you, hey, it's been 2 weeks since you got a PTI&R, we'll get another one. Like, don't forget to do this.
100%.
Don't forget to get every time you have a patient with a CHF diagnosis, we need to make sure we get a weight. If the patient can't stay on the scale, we need a circumference. Make sure we're not gaining fluids like we talked about earlier. Like all those kind of things AI can do for us. We're not saying, hey, take away from nursing or take away from doctors or diagnose patients or any of that, but use it to remind you, use it to summarize, use it to make sure you're doing the right thing.
It's a tool.
It's a tool. Just like a stethoscope's a tool.
100%.
Yeah.
100%. Doctronic is the first AI in the world to prescribe medication in Utah. Have you seen that?
I haven't seen it.
Yeah. Went live like 3 weeks ago.
So how do they do it?
It's for like $4. You can tell the AI your symptoms. I've got dysuria and I'm slightly febrile and blah, blah, blah. And the AI will say, okay, I think you have a UTI. And then it will send your prescription $4.
$4.
In the state of Utah, it's legal. And the FDA has said that they're going to be very lenient. And I'm very, very happy with the new president of the FDA. He is relaxing all of the red tape that we've been biting around this stuff. And people complain, oh, Doctronic is going to take our jobs. There's no doctors out in the bush of Utah. Like,
That's right.
okay,
What are you going to do?
You're going to move out there and practice?
That's right.
I mean, there's so many people that do not have access to some of these basic things.
I get it as you get into advanced diseases and you're trying to figure out, do you have, hormone challenges or, or you're low testosterone or do you have, cancer or diabetes and those kind of things. But for the most common person, it's going to the doctor.
Yeah,
like I have a cold. Do I have a viral infection? Do I have meningitis? All that stuff can be.
Yeah. And of course, if it gets complicated, the AI, Doctronic, pumps you over to a real person.
For sure.
I think it's fantastic.
For sure.
It's going to lower the cost of care. It's going to increase access, especially in rural areas, to underserved populations. And it can speak just about any language.
Well, that's the other cool thing about it.
I
I
know.
didn't realize this until the other day. We were talking to a patient that had that was very much spoke Mandarin only,
Yeah.
and we were having a really heck of a time communicating. She was actually an amazing reader; she could read everything, but we couldn't. How do you communicate with them? We just dropped the communication notes, and then there's no PHI in it. But here's your treatment plan. Here's what I want you to do. I converted to Mandarin in 9 seconds. It converted to Mandarin. We were looking for an interpreter and all that stuff. She can read Mandarin. She just can't speak English. Why can't we just give it to her in Mandarin? She can read it fine. She's like, oh, I understand.
Yeah, and where and how do you get a Mandarin medical translator? I mean,
It's hard to find.
even a level 1 trauma center, you don't have these people just lying around. You've got to like video in, and then it takes like 2 hours to get this done with the patient.
Well, now with Google Translate, you just put it on your
Yeah,
phone, you talk to it, and it
yeah,
translates for you. I mean, instantly. Like it's
it's
bizarre.
great.
Um,
So be excited. These are good things. And are some people going to lose their jobs? Yes. And I really appreciate Tony Robbins' recent interview with Stephen Bartlett because he talked about there's going to be like for example the self-driving trucks. 8 million people are going to lose their jobs overnight. That's way too many jobs in a short amount of time,
sure.
and so that we do need to worry about.
But I don't think it's going to happen overnight because people are going to. It's going to take a long time to get one, enough trucks, and two, to get enough trust, and three, people get out of the way, and
People get out of the way.
yeah, I mean, people got to get out of the way of the trucks that are driving. I mean, it's
Yeah.
drive around in Scottsdale, you'll understand what I'm talking about
Yeah. Yeah. But like in medicine, it's a very, very good thing.
for sure. If you use it as a tool, if it doesn't replace it, you use it as a tool
Yeah. Or like it's a scribe.
for sure.
It's a more accurate scribe.
Way more
Okay, so will some scribes lose their jobs? Yes, but we're going to find other places to put them.
for
It's
sure,
not the end of the world. I think it's fear mongering.
for sure. And I think people try to scare us with it too.
Absolutely.
But it's changing every day. I mean, it literally, the models that we use to predict, hospitalization or predict decline or predict, lupus or falls or visits and all that are changing constantly.
It's going to help reduce the amount of unnecessary visits to the ER.
For sure.
And I talked about this earlier. The ER it's the catch-all. It's all of the chronic disease failures. This was many, many years ago. The ER was so full. It was so full. The waiting room was so full. We had so many ERs backed up. It was just not a good day. And the paramedics had put this woman into this room and we're understaffed, but hospital administrators were saying, you're normally staffed. It's like, okay, we're going to disagree here. And I guess she just sat, I don't even know how long she sat in there for. And, because we had traumas rolling in. Well, I don't think we appreciated how sick this lady was. Well, she was dead. She was dead as a doornail when we
Wow.
walked into the room.
Wow.
Oh, that really sucks. She was just blue and dead and cold. And my nurse he was a brand new nurse, just fell down a fit, crying.
Sure.
And I'm mortified,
Right.
and I'm trying to juggle the other like 30 patients that I'm seeing. And would she have died anyway? Maybe. But man, had we not just tried sepsis protocol
Yeah.
and gotten some IV antibiotics and stuff. But to take it a step back and tie it into your question, maybe she had the flu a couple weeks ago and maybe she just didn't go to an urgent care or she didn't get care. Why is she septic and dead? Like this,
That didn't happen overnight.
no, this problem started probably 2 weeks ago.
Yeah.
And it ended here. And now it's our fault.
Right.
But it's not our fault. It's nobody's fault. And I'm really excited about large language models like Doctronic because maybe Doctronic is going to save more of those people's lives.
For sure.
So I'm all for it.
All right, let's jump over to your consulting company. So DKMD, I'm guessing that's your initials in MD. I got it.
Yeah.
Tell me what it is, what you do.
Yeah. It's a medical writing and consulting firm. I was doing a lot of fractional. So I work fractionally as a kind of like a chief medical officer / marketing officer. And going through our campaigns and going to market strategy, I would see like, okay, we need this white paper. We need to get these case studies written. And then you go to hire these third parties. And I mean, my God, you'll spend like $50,000 on a white paper. And I'm like, this is ridiculous. I know it doesn't cost this to do this. And so I was like, well, I have a ton of colleagues and friends that are brilliant writers and they want to get involved. And so I just called a couple friends. This was like 7 years ago. I said, hey, do you want to help me with this new stent that this company's put together? It's got a lower risk of clotting. And they're like, oh my God, that's so cool. Yeah, I'll totally help you write that. It's like, okay, well, we'll get this done for like $3,000 or, whatever it is. And so I made it out of an abundance of need for the tech startups that I was working for. And so I kind of started my own independent company. And then the next thing I knew, people were beating down my door, hey, your content's spot on. And this is back when running a blog was still, um, having a blog on your website now is not as lucrative and things as it used to be, but because people will make marketing materials and content, but it's like, if you don't really work in medicine, they don't speak the language.
That's right.
And so it was getting pharmacists and nurses and physicians writing, getting them involved in the marketing conversation. And it's been so much fun. I've gotten to work with companies all over the world, everywhere from, London to Cairo, um, pharma, biotech, med tech, just working on really cool projects. Like the AI assisted ultrasound. We did all of their blog content for like 6 months, just educating providers on here's all the cool new stuff you can do with POCUS, point of care ultrasound. And meanwhile, I'm getting to play with an ultrasound at home.
That's cool.
Yeah, so it's fun.
How's AI going to change that business, though?
Yeah,
Makes the research easier.
it does. I'm slowly dissolving it because AI can do so much of the writing.
I still think you need clinical validation behind it.
Yeah. We still need people to prove things, but the overhead, like I can't pay my friends and my providers what I used to. Yeah.
Sure.
So it's still there, but it's not like paying my bills,
Right.
But it was a really, really fun experience. It was my first time running a company on my own.
Mhm.
A lot of unteachable lessons.
Yeah. Everybody thinks it's easier than it is. For
No,
sure.
it's not. There's a dragon to slay
That's
every day.
Every day, it's right.
Every day.
And when you're the boss and you got to make payroll and you got to make lights and you got to do all that stuff, it's
Oh, but
a
I
little
loved
different.
it though. And just all the great conversations. Like one of my favorite companies, Constant Health Therapy. It's a AI speech pathology app for people with, dementia or aphasia and things. And I mean, it's absolutely brilliant. Everybody needs it. People get better. The CEO is fantastic, and we did some case studies with them. Um, but like, and I got to interview a patient, but because I'm a physician, the interview was so much better with that patient because I know what to ask. I know what to write about.
Do you think that's right? Or do you think it's because you're a physician, they'll talk to you more? They trust you?
That's a great point. It's bilateral,
It is. It absolutely is.
so those, and you're a podcaster, so you totally get this.
I'm really not a podcaster. I just run a
Or
podcast.
well,
I get it. It's easy to talk to people. I'm not a
brilliant
podcaster.
entrepreneur that
Thank
has
you.
a podcast.
Thank you.
There's something about the energy between two people
For
and
sure.
where that conversation goes.
For sure.
And you've been trained professionally in listening. And yeah, so I think you're 100% right. But like, what a fantastic, like, I had so much fun on that project.
Tell me more about it. What does the app do?
It's and same as like Credential Network. There's brilliant AI that you can embed and need into programs and software that we already have to make it faster, efficient, cheaper, all of the above. So, like with Constant Health Therapy, it's for speech pathology. And so the app will automatically tell you, like, hey, we need to work more on this area of your speech.
Got it.
And then you can hit an option like, hey, I just feel like we're working too hard. Like, okay, we'll back off. And so the AI will help, push and shove you and help you work on, or maybe it's your math. After you've had a stroke, sometimes people just cannot do math anymore.
It's scary, I know, for sure.
Well, it could be a reality for all of us. And so the AI it just kind of ebbs and flows with you to get your skills back.
It's cool.
And so, I love what I do. I absolutely love what I do because I just felt so helpless as a physician. Whereas now I'm on the other end. Like you think about all of the, for example, stroke patients in the ER that we just discharged. And and going back to like home health, it's a circus sometimes. And I hate that. I feel so guilty. And you're up late at night, like, oh my gosh, I just sent this person into what? And they have no hope of ever getting speech pathology or, but here's great new technology, AI technology that can really make a difference in their life. Okay, well, and it honestly comes full circle because a lot of these poor people who have strokes and stuff, there's no neurologist. There's none. Like,
Or
it'd take you 6 months to see a
I think
neurologist
say, or it takes you forever to get an appointment.
or a psychiatrist or,
So you had a stroke, you don't know how to eat, can't tie your shoes, you can't speak. You got to go through all this education training. If home health doesn't jump on that and they discharge you from the hospital and you go home, you're a burden to your family. Hopefully you have a family around you.
Yeah, hopefully someone will put you in the car and take you.
Right. If not, what happens? They put you in a nursing home and until your nursing home requirement or benefit runs out, and then what happens?
And you waste away. You literally waste away because you can't swallow.
Right.
Like it's a circus. And, and then so what's so cool about what I do with Credential Network, like, okay, the few psychiatrists and the few neurologists that we do have, let's get them credentialed as quickly as possible. Let's automate all of this.
Back to the circle.
Well, but it's really, really exciting. It's great for me to just feel like I'm on the right side of the train tracks now. Does that make sense?
Yeah, for sure.
I love what I do. So I love working with startups and developing content and the messaging strategy. And, like Dylan Avatar and Jeff Falconer with Credential Network, they're so motivated. So like Dylan, do you know Dylan's story?
Oh yeah, I do. He was
Yeah.
He was a jumper, or what do they call it?
Him and his wife.
They both fly.
They're just legends. I know. I watch his wife on Instagram and Facebook. Like, God.
And so that these guys fly, like they're like, what do they call that they do? It's like,
yeah, like she'll run like 5 marathons because she's awesome, and then she'll like jump off a cliff, and they're para jumpers or base jumpers.
Base jumpers. Yeah.
Well, Dylan he almost died. He had a very, very serious accident. He was in the hospital for months, and he lived, thank God. But he saw all these issues, like just saw how burnt out all of us are,
Right.
And he was like, oh my gosh, this is such like low hanging fruit. Why is this? Because he's a tech guy. He's like, why is this a problem? So he made this AI app, took a year to do it, which is you write slower is faster, took the time to develop a product that makes sense, that we need. And that's another thing. Like I work with a lot of companies, and a big issue I see, especially with AI, is these tech people or CEOs will say, oh, I know what you need. Here, you need this thing. You should use it.
Guilty.
Well, it's just not, and it's,
they don't listen to their customers.
They don't listen. That's 100% right. Fall in love with your audience, not your product.
Yeah.
And so Dylan did it the right way. Saw the issue, created a solution to speak to that problem using AI. So when they asked me, hey, do you want to work? I was like, sure. This ties in with like all of the other projects that I'm working on. It's been a blast.
That's cool.
Yeah.
That's fun. All right, let's get to the legacy question.
Oh, God.
This is a tough one, and everybody always struggles with this one, but I love it. So when your career is looked back on decades from now, which you'll be my age then, what do you want to be unequivocally true about the impact you had on patients, clinicians, and the way healthcare communicates with the world?
Yeah, and thank you for asking that. I get asked this all the time, and for the longest time, my answer was always like legacy. But it matters. It really matters. The problem is that legacy implies, because I struggled with my answer for the last like 6 months. Legacy implies permanence.
Mm-hmm.
And medicine is changing so fast. It changes too fast. I think I just care more that I leave things better than how I found them. I don't really care if people remember me or not. I think at the end of my life, when I put my head down on the pillow for the last time, I want to look back and be like, okay, maybe I didn't change the world, but I changed somebody's world with the little bit of work that I did in whatever company, and that's enough for me.
That's true. That's awesome.
Yeah, I just want to leave things better than I found it. That's enough for me.
You made an impact.
Yeah.
That's good. That's awesome. All right. If people want to get a hold of you, I'm a new startup, I'm listening to this podcast, or I'm a home health agency or hospice agency, and I want to learn more. How do they find you? Where do they get you
I only receive mail by owl.
at?
Snow owls.
Cole agree with that. You do.
Or falcons. No,
We're
find
never-
me on LinkedIn and I'll give you guys my email. Just shoot me an email.
Yeah, for sure.
I love working with startups. I like go-to-market strategy. I'm good at it. It's fun. I think I'm funny.
You are. You're really funny. You are. You're blessed actually to hang out with. So they find you on LinkedIn. We'll post your email. If they want to hire you, they can. Yeah, reach out. Well, that's going to conclude the episode. Thank you so much.
Yeah, thank you.
Yeah,
it was
awesome.
great.
It was fun. It was a lot of fun.